And for this purpose, for the purpose of getting the, excluding the secondary causes, we use sometimes mnemonics. One of the famous ones is Snoop's. It's used extensively, and it actually covers pretty much, most of the headache, secondary headaches. Now, if the patient has fever, weight loss, has some abnormal neurological findings, focal signs, sudden or abrupt onset. If the patient is over 50 years of age, it's not typical to get migraines after the age of 50. Also, the known prior history, if it's a new de novo headache, or if it's different patterns of the headache, if it's progressive. And the other secondary risk factors is HIV, cancer, anticoagulation, pregnancy. So keep in mind that these are very important, symptoms, which if you see that in the patients with a headache, with chronic headache especially, you need to think about secondary causes, and they have to be ruled out before you start treatment, and at least initiate the preventive treatment and use some other therapies. This is unfortunately a busy slide, but I just want to briefly show you how many conditions can actually mimic chronic migraine. A lot of conditions like low CSF pressure, pseudotumor cerebri, glaucoma, ocular pathologies can actually present as headaches. So sometimes tumors can present like migraine headache, and it's very important to rule it out. This slide is also important because it differentiates migraine from tension type headache. Tension type headache is actually the most common type of headache. I don't know, as neurologists, we don't see much of the tension type headache because it's more mild, and in our clinics we see mostly migraineurs. But in primary care, you can definitely have the patients with tension type headache coming and complaining about it. This slide gives you an idea how to differentiate both conditions. Now, if you see here, the female-male ratio is almost the same. It's 3:1, 3:2. And the age of onset is also almost similar. The difference is that migraineurs have auras. If you have a patient with the symptoms of aura, so it's less likely the patient has a tension type headache. For the most of the time, migraine headache is also a throbbing, and tension type headache is more like a pressure-like. And there are also associated symptoms like photophobia, phonophobia, nausea, vomiting, not common in tension type headache. Duration, again, migraine is anywhere from 4 to 72 hours. Tension type headache can last anywhere from 30 minutes to 7 hours or 7 days. Frequency for migraine usually is 1 or 2 attacks. That's what you see in the clinics for a good migraine patient. For tension type headache, they can have a little bit more frequent, like 5 or 7. It's called frequent episodic tension type headache. It's a new term in classification. And usually migraine occurs in the morning, and factors like hormonal factors, alcohol, foods, pregnancy, they have some connection to migraine. Pregnancy can make it worse or can actually make it better. Now, as with primary, when you exclude all secondary causes, then you're left with the primary headache, chronic headache conditions. Then you have to differentiate what primary headache condition, which is of chronic nature, the patient has. Now, as I mentioned before, if the patient has migraine headaches on 8 or more days per month, then it's most likely the patient has chronic migraine. If the patient complains of unilateral pain with some autonomic features like tearing of the eyes or droopy eyelid, and has some response to indomethacin, then we operate with diagnosis of hemicranic continuum. And there is a very rare headache which is called new deadly persistent headache. Usually occurs in young individuals. It's of sudden onset, sometimes precipitated by flu or a viral infection. Also considered as a benign headache. And if you have all other features which are not consistent with this, more like a pressure-like bilateral headache, then you can operate with a chronic tension type headache. So these are 4 important diagnoses when you have a patient with a chronic headaches. And today we talk about chronic migraine, but all the other conditions are different clinically and also in terms of the treatment for migraine. Medication overuse is also important to know because it's considered a chronic secondary headache. Now, we define medication overuse as the use of medications 10 or 15 days per month. This is supported by both clinic-based and population studies. Now, you can, of course, argue whether it's true or not, and some of the studies have limitations, but we have seen that if you, in some centers in Europe, when you do the abrupt stop of the medications, and after the 2 weeks, approximately 45% get better. And rest would either get unchanged migraines, or approximately 8% will get worse. But it's very important to think about it, because that can create a huge problem in the management of chronic migraine, and most of the preventive therapy would not be effective. We use several diagnostic studies to exclude secondary causes, and these are the ones which I use, but we don't have any guidelines about the usage of any labs. But it's very important to think about CBC, because anemia can contribute to headache, chronic headache. Now, thyroid disease can also contribute to the headache. Vasculitis, they're rare, but it's very important not to miss the diagnosis. Inflammatory markers, ESR, CRP, good to rule out temporal arteritis. Lyme titers, chronic Lyme disease can present sometimes with a chronic headache. RPRS test. Now, genetic testing we use for a distinct type of migraine, which is called hemiplegic, and you can actually test for 3 genes, and what we call the familiar hemiplegic migraine. There are some cases of sporadic hemiplegic migraine, and there are some centers in the world where you can send the labs. There is one in Netherlands where you actually can look for the new mutations, and that's also a possibility. And CSF studies play also a huge role, because if you have a patient with chronic headache, you will have to consider viral meningitis, or you can also measure the opening pressure of CSF, to rule out the pseudotumor cerebri. The imaging studies we used, almost every patient who walks into the emergency room gets the head CT, so with a headache, with a complaint of headache. So it can be used. MRI is also of very good option for patients if you suspect tumors. MRA if you have if you suspect any aneurysms in a patient. MRV, pregnant patients, people who are prone to have thrombotic events or disease, to rule out sinus thrombosis. CT angiogram is good to look for the sentinel bleed or the small aneurysms. And of course, conventional angiogram is good for as oral wall study. It's superior to MRA and CT angio. If you suspect low pressure headache, then you can do the MR or CT myelogram, depending what the availability is. And the last tool, which is very important in diagnosis of migraine, is a headache diary. Now, unfortunately, a lot of patients are not happy about it because they have to do some work, but it's very important for a physician and for the patient, because as you see here, this is one of the examples from American Headache Society. It has several boxes, and this box here include the headache severity and duration. Here we have headache symptoms, and here the use of medications. This will be very good tool for diagnosis of migraine, actually. You can see all the features, and if you remember the first slide with for the criteria of migraine, and if you compare, if you find all of these symptoms, then it will be easier for you to make a diagnosis. And you can also make a diagnosis of chronic migraine here too, because you have all days of the month. This is a monthly headache diary. Now, if you have a patient in the clinic already, you know about a diagnosis, then it's easier for the patient sometimes to record the headaches in this way. So the numbers count for migraine. Like level 3 is a severe migraine, 2 is a moderate migraine, and 1 is mild. And crosses is for tension type like headache. 3 for severe, 2 for moderate, and 1 for mild. You can see here a patient comes to the Danish Headache Center in the beginning of April. Then he gets the monthly diary in order to make the diagnosis. And then he sees the doctor in May, gets a treatment, preventive treatment, and then he's followed for one month. And as we told him that you have to wait at least 4 to 6 weeks in order to await the response. And then later in July and August, the headache is improved. And it's very good for the doctor to see that, the treatment you give is actually helping. And also the patient will, get it has some reward mechanisms for the patients too. So they can see that, the medications they're taking are helpful. So let's talk about the epidemiology of the headaches a little bit. Now, as I mentioned before, the tension type headache is the most frequent. The studies from US and from Europe show that anywhere from 40 to 80 to 90 sometimes % of individuals can complain of tension type headache in 1 year. The second most common headache is migraine, anywhere from 10 to 13%. It's 18% for females and approximately 6% for males. And cluster headache is the less common, it's less than 1%. And here, the chronic migraine is approximately anywhere from 2 to 3% of individuals will have a chronic migraine. Now, the common age for migraine is anywhere from 30s to 40s, and that's why if you have an individual coming with the new onset of migraine after the age of 50, you need to always think about secondary causes. You need to be more on alert for that.